hopefully it records. If not, I'll go home and record it. So this next part we're going to go over is the health information management systems as it relates to fiscal and revenue management. A lot of this information is going to be stuff that we've talked about all along, whether it's HL7 languages, ADT interfaces. This gives you a little bit more detail, but it's, again, more specifically on that part of the information system that deals with registration and billing. I'm trying to figure out how to use words, but so objectives for this are explaining the applications that need to be integrated, which they all need to be integrated, right? Describe strategies used by healthcare organizations to ensure integration, and discuss critical elements needed to integrate billing and financial and clinical, and discuss more elements related to the Master Patient Index, or the MPI, and the unique patient identifier, and the differences between those two. So in review, we have a healthcare information system components, which are the patient management and billing, department management, care delivery and clinical documentation, clinical decision support, we've talked a lot about that, and then finally this financial resource management. So patient management and billing systems support the management of the patient. So we need to identify the patient, right? That's the first part when they come in. How are we going to identify you so that we know you're this John Smith and not the other John Smith? Supporting the technology with this Master Patient Index. And the Master Patient Index has to do with all of the identifying information that's related to you. It's a source, it's a pool, and that's the difference between the Master Patient Index, or an MPI, versus a UPI. So your Master Patient Index links to patient records, facilitates patient identification, assists in maintaining longitudinal record, but it's this group of data, where a UPI is just that single identifier. So for example, your Social Security number. Your Social Security number doesn't have all this other stuff tied to it. It's just, that's your UPI. If that was used in a Master Patient Index, that difference is all the data where it's being stored and warehoused makes it an MPI. Does that make sense? It'll make more sense. So then we have the ADT interface, admission, discharge, and transfer. That's what the letters ADT stand for. And just by reading through this slide from AHIMA, it contains these specific elements that are used when we register the patient, when we transfer them, when we discharge. It's just exactly what it says. So the financial resource management systems support business functions and the organization of practice. An example is your accounts payable. And if we don't have these pieces in place, and I kind of said this in the introduction when you get out on the web, if we don't have the information to bill properly, we can't make any money. It is a business. Healthcare is still a business. If we can't make money, then we don't have the ability to pay for the overhead, which is the lighting, the infrastructure, to pay for healthcare providers. So it's very important that these all work together. And when we talked about CMS and the requirements of Joint Commission, if we don't have those specific data elements collected on the clinical side that can filter through the financial side to be reported for billing purposes, those ICD-9 codes or CPT codes, then CMS won't pay us, or the insurance companies won't pay. So that's how the clinical relates, if that makes sense, with the accounting side. Practice management systems are usually done in related to ambulatory clinic office or doctor's office. You'll hear a lot of people talk about EPM, electronic patient practice management. And it is not just the billing, but it's also has all of scheduling components as well. So it doesn't take in the clinical information for results and things, but it does take in the clinical information related to diagnoses. Sometimes there's problem lists in there, and a problem list is like a diagnosis, but it's what the patient is being followed with. So you might have a diagnosis of a broken leg that can be resolved and it heals, but you have a problem list of diabetes because we're managing that throughout the rest of your life. It's not something you're going to get cured of. Does that make sense? So these separate information systems need to be able to talk to each other, and these different parts be brought into the single system. And we do that. There's a lot of information on these slides. When we integrate, and in the next couple slides, you're going to see we're doing that with health level 7. And some of you have written some, in some of those discussion forums, have reviewed some of the health level 7 and ANSI's requirements. When we talk about the application integration, we've got the management and billing, obviously, we're tracking the patient. Department management, so when we track these patients, like what's happening right now at community, is we're trying to figure out the patient's registered to the location of ICU. That's where their bed is, 302. And when revenue goes back, if I do a procedure as a nurse in the ICU on that patient, and that procedure can be billed for, so inserting a Foley catheter for urine collection, it goes back to the ICU department. So we use it for productivity. So then you come into this department information. It's productivity, it's revenue that goes back so that we can either restock supplies or buy new equipment for the ICU. That's how we're delineating that revenue that comes back into the departments. And that next part is how it's driven by order entry and result. And it try not to be too confusing, but what's happening is, so that patient's in ICU, that's where they're registered to, it's that location, based on the patient tracking. But they need to go down for surgery. We don't transfer them, this ADT interface that we talk about, we don't transfer them physically out of bed 301 electronically in the system, down to surgery and put them in surgery bay 2 in the system. And then when they're out of surgery, bring them back and change them in the electronic system to 301. Okay, they're always in 301. We've just physically moved them down to surgery for this couple of hours because they had it scheduled. If in surgery they put in that Foley catheter instead of in the ICU, surgery needs to get credit for that. But we haven't changed where the patient's location is in the system. So the computer's only as smart as the programmer, right? The computer doesn't know the patient's in surgery getting that. How do we get the order for that Foley when it's completed and recognized by the right department based on where the patient is being tracked? Am I kind of losing you? I'm really fighting with this in our system right now because the computer can only do so much. And that's why it's so important all these things talk together. So either we have to change business practice to address how we're going to sort that revenue between the departments, or we need to really figure out how the computer can do it for us with the different ways we can program it. Right now, we haven't figured it out yet. Did that make any sense at all? It's kind of when you haven't been in there, but basically the patient's just temporarily somewhere else, but the computer doesn't know that because everybody has access to this one application. So again, when they're putting in, this just keeps going with the same thing. I didn't realize, sorry about that, but I had the information across the slide. The decision support, so computerized provider order entry, that physician can be anywhere. That's why we talk about with these electronic records. He could be at home putting in those orders. So the computer doesn't know he's at home. The computer thinks the patient is in 301. The patient's physically in surgery. And we can do some things by the person that's doing it. So Nurse Carrie belongs in ICU. So if I do it, yeah, we could say Nurse Carrie did it, so therefore it's ICU. Nurse Susie does it, it's OR. The problem is that nurses float. So I could be a med surg when I do something. So again, it's all going back to this, how do we get it back to resource management and patient profiling by understanding what the needs are. On another resource management, when we talk about resource, we talk about scheduling as far as physical therapies. Right now we're doing the same thing. Related to computerized provider order entry, they put it in order for evaluate and treat. So the scheduler doesn't have anything that says specifically ambulate the patient for 1 hour or whirlpool for half an hour if it's a wound. And the whirlpool, there's only one of them. You have to split it between all the patients. That's considered a resource. So that's another thing that needs to be considered when we're building these orders, how it relates back to resource management and scheduling that's in the business side. And that's another component I've been working on right now is the order is evaluate and treat. Where do we put these comments or how do those comments flag the scheduler to know exactly what resources she needs, whether it's a physical therapist, an occupational therapist, a wound nurse, whether she needs another type of static resource like a pool or a whirlpool or a particular piece of equipment or device that needs to be managed because there's not enough for everybody, so it had to be scheduled. And then making sure that information gets back to the financial side if there's some of those resources that actually affect billing. You could say you do a wound care, but maybe bandaging is part of a lump charge for wound care, but there could be an extra charge if we actually put them in a hot tub or a local tub. So we need to make sure if that's scheduled that it flows back to financial with the appropriate documentation so we can bill for it. So the first strategy of data preservation must be developed by providing access. We've talked about that, right? Access comes in all forms. Security, the availability of the actual devices. If you don't have enough computers for people to log on to, if your infrastructure isn't strong enough, you can't get access. How you're going to manage this data, where's it going to be warehoused, and the user interface. So when we talked about those forms and the data collection devices, what that user interface is going to look like so that you can collect the data appropriately. So we make sure we get those ICD-9 codes on the clinical side so they'll flow to the financial side. So from a whole enterprise, and the enterprise is the whole facility, we've got, again, that master patient index. The user interface comes with a single sign-on, so it's easy for the user to access what they need, when they need, in a timely manner. And it's all of our quality stuff, that it's accessible, timely, and efficiently. And then the warehouse, how that information is being cataloged and stored so that, again, we can easily access it. It's been indexed properly. The database has been normalized in such a way that we can efficiently get that data. See how this is all kind of coming together a little bit? So some key components include that structure, so having that unique identifier so we can easily, or a primary key, where the primary and foreign keys talk to each other in that data warehouse so that we can easily get that information. Standardized vocabularies, we talked a lot about that with meaningful use in the last couple of lectures, so that we're all speaking the same thing. So again, it's all data management. I can't, if we're all speaking different things, then I can't talk to St. Pat's, right? Unless we're using some standardized fields. The content exchange, and this is where we get to that health level 7 language standard, and then your privacy and security, which is related to that access and how we're going to keep that data safe. Which still look up, right? Here we go. So available whenever it's needed. That it's integrated. We talk about this big system in the hospital when we're putting in Cerner. Everyone needs to be able to see what's going on with that patient in real time. There were some suggestions that maybe respiratory therapy didn't need to see how much intake and output the patient had, their eye nose, how much they ate, how much they peed, how much they drank. And we're like, well, why not? I mean, if they're treating a patient with congestive heart failure who's on Lasix, which removes the fluid off your lungs, they need to know that, or they're not going to know if their breathing treatment's appropriate, or if it's making a difference because they still have fluid on their lungs because they didn't get their medicine, or there's all those kinds of things where we're like, we're smart people out there taking care of you, but only as smart as the data we have in front of us, and to make these good clinical decisions to improve patient care, we need to see it. It's sad because people are so caught up in their privacy, and it is private, but that's why we're trained healthcare professionals, is to understand how to treat that data, but if we don't have it, we can't treat the patient. You have to have an interface engine. We have OpenLink, which is a third-party interface engine that takes this information from one system and translates that HL7 to make it go to the next system. So when results come out of our lab system, it goes through OpenLink. OpenLink makes sure that all the characters are in the right fields in the HL7 so that it can transmit that result where it needs to be into the next system. And when we did the database lecture, some of y'all challenged how the database looked. So why would you build it that way? And I'll just reiterate, we don't have a choice. We've got a lab system with its own database in it. We have the ER system with its own database, and they're separate. They're on separate servers. They're not even the same SAN array. So physically they're separate, and we're trying to make those results in order to go from one system to the lab, and the lab to send those results back. It's not as easy as we didn't have to build it, so we didn't get to choose what our primary and foreign keys were. And that interface engine sits in the center, and that's what it does, is try to translate those keys and stuff to make it all talk to each other. So it translates those different protocols. It sets the format, facilitates the sharing, all these things. And an example of that, so here's a better example, because I'll talk about the ADT interface. So a patient gets registered right now to our labor department. We've got the New Women's and Children's Center over there. It's in Siemens Envision, totally separate program. It sends that ADT message to OpenLink. OpenLink translates it to send it to GE's Centricity, which is their electronic system currently. In Envision, because of the way we have to do billing, we have room 110. In Envision, 110 actually looks like there are 5 beds. We have 110, which is just a straight standard charge. We have 110A, which is a standard labor charge. 110L1, which is an acute labor charge. So the patient's struggling, or they need their higher level of care, they're eclamptic, pre-eclamptic, or high blood pressure, they need special meds. And there's a labor 2, which is a person's probably going to go for a C-section, and then there's a recovery. So the patient's had the baby, it's a postpartum charge. So I guess it's before they labor, a labor charge, an acute labor charge, a surgery labor charge, and a recovery charge, a postpartum recovery charge. That's built in the system with beds. So the message comes out and says that the patient in the HL7, and when we get to HL7, it'll make a little bit more sense, but the bed number is 110-A, 110-AL, 110-AL1. So that message is what's coming out of the registration system. But the OB system doesn't care what the charge is, because the OB system just takes that information and puts the patient up on a big tracking board in the right location, right bed. So it just needs to know they're in bed 110A, B, or C. It doesn't care if it's an L or 110A1. That physical bed doesn't exist. You with me? So what the interface engine does, what our interface analyst has done, is when that message comes in, he's got the programming written so that it strips the second character off of that. The second to the last character. It's written as the second character, but if it was, you guys get to see a picture, not recording it. Sorry for those listening at home. So if it comes in as 110AL, he tells the engine to strip that off. So it just comes in as 110A when the other system sees it. That's what the interface engine does. So it translates between those two so that then the other system recognizes these patients at 110A and puts them appropriately for documentation purposes, for tracking purposes in that system. Does that make sense? So how's level 7? Again, some of you have read quite a bit about it. You may even know more about it than I do, those of you that have other IS classes. But these standards, I'm not going to go into all the background of it because that's what most of the other discussions were. That AMC came up with this. That's a nonprofit organization trying to standardize the messaging that comes out of these different equipments and different applications. And by equipment, what's really important when we're talking about infrastructure and health information technologies is blood pressure monitoring machines, heart monitoring machines, ventilators. They are being required to have this HL7 is how they communicate. And if you have older devices, they're not HL7 compatible, then we can't make them talk to the application. And for efficiency's sake, what we're trying to do is you have your blood pressure monitor, it's got all your vital signs. So your temperature, your blood pressure, your heart rate. And because it's in HL7, when the nurse goes to document, this blood pressure monitor, the physical box over here, can send that information, that data, discreetly. So the blood pressure goes to the blood pressure field, the respiration goes to the respirations field, the heart rate goes to the heart rate field within the clinical application. So she doesn't have to look at the monitor and hand key that data in. It just flows right in there. Using this ADT interface, we get the patient's name, we correctly identify them, it links up to that other application, and that data pulls forward into there, so we don't have to key it in. That's what HL7 is doing for us. And the standardization is what makes it possible. So here's what HL7 looks like, and this is just the first part, and it's a lot to look at. I've highlighted some things on the next slides to make it a little easier. But starting in the very top left-hand corner, and I can point for you guys, but since I'm not recording, I'm going to see it. MSH, PIB, PB1. These are all segments. So very briefly, for those of you that aren't familiar, a segment is designated by this 3-character unique identifier. In every segment after that, it's a field, and the fields are delineated by pipes. So there's your field. See the 3-character fields? And then there's your pipes. And each one of those is a field. And you'll notice that some of them, after that number 1, so account manager, pipe 1, and then you have pipes with nothing between them. These fields are available. If that information is collected, it can be used. But there's nothing in there, and that's okay. So in the message header, and when the pipes, you count between the pipes. And so there's a whole table that tells you what all this stuff means. And field number 8, field number 9. Field number 9 is the actual message. And if you notice, field number 9 is right here. It tells us it's an AO1 message. AO1 means it's a new registration. So there's a whole key code of what these AO codes mean. AO1 is a new registration. AO4 is an update, or AO8 is an update. AO4's, I don't have them all listed out, but it's actually what I need to know because that's what I'm looking for when I have something that breaks between, say, the ER system and the lab system. That's exactly what I'm looking for. What message did I get? And where did it come from? What type of message? Did it get nacked or not? And so if you count, starting with the MSH, the first pipe, 1, 2, 3, in between these pipes, 4, 5, 6, 7, and that is 8. Did I miss one?
Yeah, okay, your MSH, that's 1.
Yeah, okay, so I missed one when I was counting. It really is 9. And that's what they standardized. They said in field 9, you will always have, in segment MSH, you will always have the type of message. This next segment is the patient identification. That's what PID stands for. AMC, HL7, has said in field 5, you will always find the patient's name. In field 8, you will always see the gender when you're in segment PID. In field 7, you will always see the date of birth. So if we were to count, this patient's name is Donald Duck. Be obvious. What's their date of birth? Yep. So,
1924,
yep. So it's October 10th, 1924. So in field 7, if you were to count, field 7 has the date of birth. So it says in field 7 you'll have a date of birth, but then it also says it has to be in this format with four characters for year first, then your month, and then your day. So it should be YYYY, and then DD. And unfortunately, they made it 1010 instead of like, I don't know, 0131 or something, so I could to make sure that I'm really saying it the right way. But then the next part is going to be their address, 111 Duck Street. So all of these things are in there, in those fields, and when you understand them, it's actually very easy to read that big mess that you first saw. Any questions about HL7? So the revenue cycle is where system integration is essential. AHIMA defines the revenue cycle as the process of how the patient financial and health information moves into, through, and out of the healthcare facility. The end result is the facility receives their reimbursement for services, right? That's kind of what we talked about at the very beginning. We don't have all of these things working together. So we've got admissions, lab, radiology, surgery. These are all considered disparate systems, and even in Cerner, when it's one system, these are different areas, which is back to that challenge of how do we get revenue back to those specific areas when it's in all one system. So we have to identify them separately, get all that data together, be able to meet meaningful use in order to get all of our benefits, all the reimbursement that's coming to us. And most of those meaningful use things are driven, that's this next part of high tech, why high tech's out there is not only is it having that ICD-9 code and the documentation to support we actually did this procedure or they actually have this diagnosis, so they'll reimburse us. But then if we don't have those other specific things that they're trying to track with meaningful use, gender, race, language preference, some of those things, they won't reimburse us even if we have the other parts of it. So it all has to be together. There is software, these business intelligence applications that help with this data analytics, correlation, and trending. So all of this data we're collecting, and this is where the stuff I do comes into play, is being able to take all that information, now that we're collecting it, we're using HL7, we've got some standardization, and make some sense of it, pull it all together. And if you notice in this lovely little peach thing, turn data into information, information into knowledge. Does that sound familiar? Lecture, very first lecture. What is informatics? Data that's stored, turning it into knowledge, turning it into wisdom, being able to do something with it to improve patient care, right? There's different types of analytics. So we've got your clinical and financial. Decision support happens on the front end right away. That's that allergy interactions, drug-drug interactions, so it can happen right away. It can be done with query and reporting, so it can be after the fact in retrospective review. And scoreboards and dashboards, and those are the things that if you ever go out and see, how's the hospital doing overall? CMS will post oftentimes based on how many patients died in your facility over the last year. It's huge. And it may not be our fault. Always know where your data's coming from. So the patient arrives in the ambulance and we do CPR in the ER. The patient may technically be dead when the ambulance brings them in, but because we call it, we get a death mark. And so understand that it's not because we're killing patients. We're providing good care, really. Yeah, we just get to take credit for it. So again, the master patient index is centerpiece for all functionality. So it's the health record, linking the scheduling, reporting, all of this information together. It's important because this is on my next one. Sorry. It's the directory that references all of those things. That's the difference between the MPI and the UPI. This is the directory, has all that stuff together. The UPI is just this little identifier that makes that patient unique. So it indexes, ensures accurate and complete linking between all of the parts of the EHR, establishes streamlined governance processes, and accurately matches persons being registered for compare with their existing medical records. Some core elements of the MPI are going to include these things, which also, anybody recognize them? Meaningful use. These are the things we're being asked, right? Their sex, their gender, their ethnicity. And, there's the UPI. So do you see the difference? The MPI has all that data, including the actual identifier that makes them unique. And when we think about, you'll see the assignment is to try to come up, this is the challenge, and the next part of the lecture is the challenge, we don't have a way to come up with a UPI yet. My husband joked, if for my master's thesis I should figure this out. I said, you know what, they've been working on it for 10 or 15 years and haven't figured it out. If I can do it, I'll be a very wealthy woman. But when we look at some of these things that are required, right, a person's name, what if they get married? What if they choose to legally change it because one of my professors was male, but he changed it back to the original name that they came over to Ellis Island with. So you could change your name. So today I'm Sally Smith, but a year from now I'm Sally Jones. So how can you use name to be your part of your unique identifier if it could change? My date of birth shouldn't change. Can my gender change? Potentially. I mean, we're going there. Race and ethnicity probably don't change, but do I even know what I am? I mean, we have lots of people that, I have some blonde-haired, blue-eyed Native Americans. People are uncomfortable asking what your race or ethnicity are. They don't like to ask those questions, and so they assume, I have triage nurses, they'll assume because you're blonde-haired, blue-eyed, well, you're definitely not Native American. No, they're qualifying themselves as Native American. They've got more than 50% in them or whatever. What's at higher risk for heart disease? What's at higher risk for diabetes? It's important to identify. And it's not about discriminating against them. It's about how do we provide health care, because your race and ethnicity can affect certain genetic factors and predispositions. Address and telephone number, can those change? If you have a social security number, it shouldn't change, but if somebody steals your identity, they can issue you a new one. Does everybody have a social security number? There's a lot of healthcare, sometimes even I get a little isolated in the world I live in, but we have migrant workers that come into the Wenatchee Valley in Southern California. They're here legally, but they don't necessarily get a social security number. So this is the challenge, is what information are we collecting at registration that we can use to pull together to make a unique identification. Admission, encounter, visit date. We use these combinations when we're trying to assign certain services and things. So you'll come into the ER and you'll get an admission, encounter, and visit date. So we admitted you to the ER as an outpatient. You get assigned a 10-digit number or whatever. That's your billing number, your encounter number. And it has this visit date of today. So after we examine you, we think that you need to come back and have an additional x-ray or additional lab work. It's not necessary to do it in the ER because it's going to cost more money for you. And it's just a follow-up. Maybe we need you to wait 24 hours or something in order to recheck something. See if there's changes. When you come back the next day, that's a new admission, a new encounter, and a new visit date. That's how we separate it out in the bill. It's how we separate it out to keep track of things. When you call in and you say, well, I was there on the 24th, well, it would get really confusing if we had the same encounter for the 24th as we did the 23rd. It gets a little jumbled. So it separates all those out. Encounter service type, encounter service location. So you'll get registered with this unique identification that says your hospital service, your service type is EMV. When you come into the lab, it's going to say you have a different number for that encounter, and your service type is going to be LAB for that lab. So that's all back in this financial system. We always ask you for a physician, and then we need to keep track of how you left. The reason being is if you get admitted, so you're in the ER and you get admitted, this is a little bit with you. We actually have to use the same encounter number even though your service changes because Medicare has a 72-hour rule. It says if you've been seen more than once in 72 hours and you have Medicare, we can only send one billing out. We can't use different encounter numbers. So then we're back to scrambling our database because now I have one encounter number over multiple visits. That's the other job that I do in the background is cleaning some of that stuff up. So the unique patient identifier. Permanently assigned to an individual, think of it like your social security number. If we could figure this out, it's an entire national healthcare system, and hopefully will be globally. If you went to Switzerland or Germany on a trip in the next 10 years, that's what we would hope, is that somebody would be able to look you up and know what your allergies were. If you were hurt really bad, or you couldn't talk for yourself, or they didn't understand your language, they'd be able to look up at least what your allergies were and a little bit of your past medical history and know this is acute asthma attack because you have a history of asthma. Is it an allergic reaction because you ate some food? You were drinking German beer and you're allergic to wheat? Cannot be shared with any other individual. So again, if in a social security number environment, if somebody else comes up with your social security number, happened to me, went to do a ride along the police department, had to do an FBI background check. Some lady in Pennsylvania was using my social security number. Didn't do anything bad. She had just given it when she got arrested. Not because she knew it. She just rattled off random numbers. Just happened to hit mine. Win the lottery here. She got mine right. So if that were to ever happen, if there were two of these numbers that came up with this two different, information, that shouldn't happen. So then it really should be unique to the individual, and it would need to be looked at to see how did that happen. And that's part of the integrity of that data. Must support that identification of individual, identification of information, so that's why it's part of the MPI core components, so that you can identify all the other aspects of information, the lab results and things, and reduce the operational costs. And how are we going to do that? Because in an integrated system, we won't have repeat labs. They'll have access to those results. All of that stuff will talk together. We'll know what your medications are, so hopefully you don't have an adverse event from taking too many meds at the same time and end up in the hospital. We can track some of these things, help with the maintenance like diabetes, because if everybody can see the same information, everybody's on the same page, then we can provide care across that continuum regardless of how many providers are taking care of you or where you might be seen in another country. HIPAA requires unique identification numbers. Don't have one UPI yet, so what are we doing? Well, when you get registered, we're asking you your social security number. California, you're not allowed to ask, at least last I heard. We're asking a date of birth. So we're trying to create a series of fields that will act to help identify you correctly. And the OMC has this matching power team where they've been working on this. This is where I said they've been working on it. Here I am just lecturing away without even knowing, and then I get to the part I don't know about. So they were examined by, the potential matching attributes were examined by this patient matching power team, and they concluded that having a common base set of attributes is important if they're going to achieve the acceptable level of sensitivity and specificity. So again, we talked about your name, date of birth, trying to come up with a base. What are all these qualifiers and how they're going to smush them together to come up with a UPI? And they're still working on it. Haven't done it yet. So in summary, we talked about administrative, billing, and the financial systems and how they have to integrate with clinical in order for us to get appropriate reimbursement. And again, we've got to be able to match those things up when we're sending them to the companies, what the clinical documentation was versus what the billing was. So the date and time of the visit, the encounter number, has to match the care that we provided at that date and time as well. Doing the data analysis for trending. Strategies that healthcare organizations need to use or consider, like having hardware that uses HL7 so it can talk easily. the critical elements that need to integrate with the billing and financial and clinical systems, identifying what those elements are, that we need the diagnosis code, that we need the procedure codes, and how that comes out of the documentation. We need the doctor's order, CPOE. A lot of things we can't bill for if we don't have an order. So you have to have an order from the clinical side to match the codes that your procedure codes you're sending on the billing side. The master patient index, and the UPI. Then you've got lots of references there. We have fun with those. Any questions? Be excited. It's like the last week, right? We've got next week, and then you'll miss me terribly.
Is there any more assignments or work?
5.2 and 5.7.
And they